Welcome, everyone. We're so glad you can join us for today's webinar on expanding access to methadone treatment for opioid use disorder in carceral settings. My name is Braden Kelly. I'm the Managing Director of Initiatives at Addiction Policy Forum. We're part of the Coordination and Translation Center for JCOIN, the Justice Community Opioid Innovation Network. JCOIN is working to study and disseminate solutions to improve care and outcomes for individuals with substance use disorders in criminal justice settings. Today's session is part of our JCOIN speaker series, where we feature priority topics identified by you all in the field, and that features the latest research, science, and innovations in our communities. Before I introduce our speakers for today's webinar, I first want to thank Julia Rosenberg on the APF team for really helping coordinate and pull this whole webinar together. She did such a great job organizing it. I also want to mention a few housekeeping items. If you have any questions at any point during the webinar, you'll see at the bottom of your screen, there's a Q&A section. You can add them there. We will have Q&A at the end, and whatever questions we can't get to, we will follow up about. We'll also provide certificates of attendance to everyone who has joined us, and we'll get those out later this afternoon. Now I'd like to first introduce Dr. Tisha Wiley, who is the branch chief of the Service Research Branch at NIDA and the Associate Director of Justice Systems at NIDA. She directs the JCOIN initiative overall and oversees its direction and activities. Tisha, I'll hand the mic over to you.
Great, and thank you, Julia, for helping organize this. And I really want to thank Dr. Ramsey for sharing her time and expertise with all of us, and for all of you. I see over 300 people have joined us so far, so thank you for joining, and clearly there's a lot of interest in this topic in the field. I'll just say just a couple words about JCOIN and what we hope to accomplish and where we're at with JCOIN. We launched JCOIN in 2019 as part of the Helping to End Addiction Long-Term Initiative. We came with a large initial appropriation from Congress, and we've been fortunate that Congress has continued to appropriate money for the HEAL initiative here in JCOIN as we continue our work. We are now, NIH operates in 5-year cycles, and so we are now at a nice transition point from our first phase of JCOIN into our second phase of JCOIN, and we are hoping to fund new grants next year to continue to do this work. But across both phases of JCOIN, our guiding vision is this idea that every person who's involved in the justice system that has a substance use disorder should have access to effective treatment. And the way that we've approached that challenge and that problem within JCOIN has been about really building partnerships across community and justice settings and bringing in researchers as part of that partnership to build new evidence about what works and to support efforts to get that evidence to scale. Really try to build out resources for the field. This is one example of a resource we hope that the field will find useful and build capacity. So one of the things that we do know is very effective are medications for opioid use disorder delivered in settings. I think one of the most exciting policy changes in the last year has been this change around the hospital clinic designation. I really think my SAMHSA colleague tells me it's a clarification, not necessarily a change. But I think it has a lot of important potential. So I'm glad that you all are here to learn more about it. Really excited for the partnership with Dr. Ramsey to share this information with you. So I will stop talking now. And I just want to express my gratitude to everyone for their work and all the efforts together to advance that idea of making sure that we get effective services and treatments out to people in the settings so that they have chances to recover and to rebuild their lives in a positive way. And so with that, I will turn it over to Dr. Ramsey.
Thank you, Tisha. I really appreciate you giving a little bit of background about JCOIN. We really appreciate JCOIN for really making these forums possible and really being responsive to requests from the field to provide more information and details about emerging topics such as this one. Now I'd like to introduce Dr. Kelly Ramsey, who is a board-certified internal medicine and addiction medicine physician who has treated substance use disorder since 2004. Kelly works as an addiction medicine and harm reduction consultant, as well as providing low-threshold clinical care in addiction medicine. She's provided expert advice to the New York State Department of Health serving numerous capacities for over 15 years and providing expertise in addiction medicine, harm reduction, HIV care, and HCV care. Kelly, the floor is yours.
Thanks so much for having me. And first, I want to apologize because my camera is not working in Zoom today for whatever reason. So that is the only reason I'm off camera. I do not have any financial disclosures, and I'm going to dig right into the topic so we have plenty of time. Our learning objectives today are, after this webinar, attendees will be able to describe the effectiveness for medications for opioid use disorder, or MOUD, for the treatment of opioid use disorder. Describe what the use of the hospital clinic designation in carceral settings means and how it expands access to methadone in carceral settings. Describe how to operationalize use of methadone effectively for the treatment of opioid withdrawal syndrome and opioid use disorder in carceral settings. And lastly, understand best practice in carceral settings for the treatment of opioid use disorder with methadone. So first, I want to do a little bit of background and level setting. Hopefully everyone is well aware that methadone is a life-saving medication for treating opioid use disorder. We know that it is clinical best practice to offer all 3 FDA-approved medications for the treatment of opioid use disorder, including methadone, and that would be in all settings, including carceral settings. Managing withdrawal from substances in carceral settings is important because deaths can occur when it is not managed effectively, and those deaths are preventable. So unfortunately, counties and carceral administrators and carceral staff have faced civil lawsuits seeking monetary awards and other relief when they have not provided withdrawal management effectively. Treatment for opioid use disorder in carceral settings also is important because substance-related overdose is the 3rd leading cause of death in jails following illness and suicide. Johns Hopkins University, with which I am consulting around this project, did release a prior report called How the Drug Enforcement Administration Can Improve Access to Methadone in Correctional Settings and Save Lives, where they outlined the provision of methadone in carceral settings as a benefit to incarcerated persons. And unfortunately, without using hospital clinic designation, if you don't have OTPs near you geographically, you may have been limited historically in your provision of methadone. So I'm going to go into a lot more detail about all of that. So first, again, just to make sure everyone is aware that both methadone and buprenorphine, 2 of the 3 FDA-approved medications for the treatment of opioid use disorder, are associated with a significant decrease in mortality, both to opioid-related causes or overdoses, as well as all-cause mortality. In contrast, extended-release injectable naltrexone, name brand Vivitrol, is not associated with either all-cause mortality decrease or opioid-related mortality decrease. This comes from a document that was called Mortality in Local Jails. It was looking at about 20 years of data. And on the left-hand side, you can see again that drug alcohol intoxication or withdrawal is the 3rd cause of death, 3rd leading cause of death in jail settings. On the right-hand side is looking at adjusted mortality rates per 100,000 US residents by cause of death in 2019. And you can see that among jail inmates, suicide as well as drug and alcohol intoxication or complications thereof are significant causes for death. This is looking at the percent of deaths of local jail inmates by time served before death. And you can see that the particularly vulnerable time is those individuals who are in their first 7 days or less in a carceral setting. So that would be the time where withdrawal would be present. This is looking at mortality rates among former inmates, specifically of Washington State Department of Corrections. And they were looking at study follow-up overall and according to 2-week periods after release from prison. And you can see that there's a spike in death, particularly early after release in that 1 to 2 week period. And that's most specifically due to overdose. So here from that same study, the leading causes of death after release from prison and overdose, as you can see, was a significant cause of death. This study was looking at fentanyl-related overdoses during incarceration And this came out in Health Justice Journal in 2021. And you can see that the number of overdoses overall has been increasing, particularly in the fentanyl era. This is data that it was published in Lancet in 2022. This is looking at post-incarceration outcomes of a comprehensive statewide correctional MOUD program, and this was looking at the state of Rhode Island. And you can see that if people were initiated before release onto buprenorphine or methadone, but highlighted as buprenorphine here, they were far more likely to stay engaged on buprenorphine post-release. So again, significant differences in the number of people who were able to be continued on MOUD after the carceral setting if they were introduced to it during their time in the carceral setting. This is looking at post-incarceration fatal overdoses after implementing that universal MOUD program in the Rhode Island correctional system. So there was a 60.5% reduction in mortality after the MOUD program was introduced. So the number needed to treat, so how many individuals did you need to treat with methadone or buprenorphine to prevent a death? And that number was 11. So those of you who aren't physicians may not realize that number needed to treat is something we commonly look at when we're looking at the efficacy of a medication and also looking at cost effectiveness. So the number needed to treat of just 11 to prevent an overdose is very low with respect to a number needed to treat number, which often is much higher, including for medications that we think of as very efficacious, for example, with high blood pressure. This is again looking at the implementation of the statewide MOUD program. And again, you can see those numbers really increase for the number of patients who were on one of the 3 FDA approved medications when they made it universally available within the carceral system. So now I'm going to move into more of the bulk of what we're going to be talking about for the rest of the webinar. So what do the updated final rules of 42 CFR Part 8 that were recently published by SAMHSA, so released in February, but then promulgated officially in April, say about the provision of methadone in carceral settings? So this is from the 42 CFR Part 8 rules. If a correctional facility has registered as a hospital or clinic, a physician or authorized staff may administer or dispense narcotic drugs to maintain or manage withdrawal for an inmate as an incidental adjunct to medical or surgical treatment of conditions other than addiction. So this was actually the hospital clinic designation was part of the rules for 42 CFR Part 8 before 2024. However, it didn't explicitly refer to correctional facilities or to long-term care facilities. SAMHSA has now corrected that and added those. So again, correctional facilities, that is either state prisons or county jails, can feel comfortable using the hospital clinic designation. So what is the interpretation of the rule? The revised rule clearly states that a carceral setting, if they have registered with the DEA as a hospital clinic, can treat patients with methadone under that exemption that's available to hospitals and clinics. So you don't have to be a hospital officially, you don't have to be an official infirmary to get that designation, but that is what the designation is called. So under that exemption, the hospital clinic can dispense methadone for the treatment of acute opioid withdrawal syndrome and or do ongoing treatment of opioid use disorder for patients, meaning they can both initiate methadone and continue methadone, provided they have an additional diagnosis. So this is a little bit of a sticky issue, but they do have to have another diagnosis besides opioid withdrawal syndrome or opioid use disorder. The guidance does not list or otherwise specify what those additional diagnoses could be or should be, which does give some leeway to the medical provider who is making that decision. There should also be clear documentation in the medical record identifying what additional diagnosis the patient has. And we'll talk a little bit about that more in a few minutes. So currently, what are the options for providing methadone in carceral settings? So the carceral setting can become an opioid treatment program, or OTP, itself. If it did that, it would have to follow all of the 42 CFR Part 8 rules that an OTP must follow. The carceral setting can establish a relationship with a community-based OTP to provide methadone for patients in its setting. And then lastly, the carceral setting can utilize this hospital clinic designation to provide methadone for its patients. What diagnoses may be utilized in this setting as an additional diagnosis? So this hasn't been determined yet. So the DEA and SAMHSA have been discussing the issue. We are awaiting SAMHSA guidance on this issue. Most broadly, I would hope that it would be an individual with any other diagnosis besides opioid withdrawal syndrome or opioid use disorder. But right now, we don't have that information. So, for example, if a patient had a diagnosis of hypertension or diabetes or pregnancy, all of those diagnoses should be perfectly acceptable as another diagnosis. What we're waiting to hear on from SAMHSA is if another substance use disorder diagnosis can be utilized or a mental health diagnosis can be utilized. How can a carceral setting register with the DEA as a hospital clinic? So the process is pretty straightforward. There is a form available online called DEA Form 224. I put a hyperlink there to it that asks for specific information such as the address of the facility and the DEA registration number of the providers supervising the clinic. There are many jails and prisons that already are registered with the DEA as a hospital clinic. So therefore, if they already have that designation, they can go ahead and utilize methadone. It is important that you're aware of any additional state requirements that may be specific to your geographical location. So the state may have licensing requirements for hospitals or clinics. You may need to be licensed by your Department of Health, et cetera, or your state equivalent of the DEA. You also should probably be in communication with other state regulators, such as your state opioid treatment authority or your SOTA, so that, again, you're aware of any particular requirements or licenses or registrations that you may need to do this. What is the DEA 72-hour emergency rule for methadone and buprenorphine, and how does it apply to carceral settings? So the DEA 72-hour rule, or what's commonly called the 3-day rule, allows practitioners to dispense up to 3 days dosing to a person with opioid use disorder from a stock supply of methadone or buprenorphine at the facility. So most typically, who uses this rule is most typically hospital emergency departments, but the rule applies to other settings as well. So for example, if you use the rule in the carceral setting, it would allow for uninterrupted treatment with methadone or buprenorphine for an individual, for example, who arrives at the facility or is released from a carceral facility on a weekend. So this is really important for individuals who are being treated with methadone because they may not be able to access methadone until they make it to the OTP that the carceral setting has set them up with. And we'll talk more about that in a few minutes as well. So methadone being different from buprenorphine because methadone for the treatment of opioid use disorder cannot be prescribed to a pharmacy and be dispensed. It can only be either dispensed from an OTP, or if a carceral setting is using this designation, then you can dispense the methadone to someone who is being released, so they have a 3-day supply before they present to an OTP. In contrast, the buprenorphine can be prescribed directly to a pharmacy and dispensed to the patient. So again, important to check if your state regulatory authorities have added any rules on top of the federal rule. So an example is in New York State, there was a state-specific rule that originally was in compliance with the federal rule when you could only dispense 1 day or 24 hours at a time, but it didn't keep up with the change in the federal rule allowing 3 days to be dispensed at one time. So we have to wait in New York State until that rule is changed before giving us the leeway to dispense 3 days at one time. So if you need more information on that rule, I've put a hyperlink to a Health Management Associates or HMA brief that was issued earlier this year. What is the role of state regulations in ensuring access to methadone for entities regulated as hospital clinics, and how can state policymakers be supportive of the hospital clinic pathway? So I think there's been a lot of confusion in general around the hospital clinic designation and the utilization of methadone for acute opioid withdrawal syndrome management and OUD treatment, even in hospital settings, so a legit hospital setting. And so often, if there's an absence of an addiction medicine consult service in a hospital setting, then methadone is often not utilized for treating that acute opioid withdrawal syndrome that's occurring in, say, somebody who is admitted for endocarditis or another clinical diagnosis. And so individuals are not being treated with clinical best practices. And so to ensure that the SAMHSA rules are understood clearly and applied in settings that qualify for the designation, state regulators overseeing hospital clinics, OTPs, and carceral settings could issue clinical guidance that could eliminate any confusion, and also they could eliminate any state-specific regulations that add additional oversight to federal regulations. What are some factors that county jails and state prisons should consider for utilization of methadone? So as I mentioned, methadone is a very, very effective medication for both the treatment of acute opioid withdrawal syndrome as well as for the long-term treatment of opioid use disorder. So it's a long-acting medication. It is a full agonist, meaning that it fully activates the mu opioid receptor. And again, as I mentioned, has significant decrease in mortality associated with its use for individuals with opioid use disorder. And in addition to the decreases in mortality, it reduces recidivism for individuals who have been participants in the criminal justice system. However, due to the variability in how methadone is metabolized by the individual and its long half-life, the administration of methadone does require some clinical expertise and clinical oversight. So I'm going to just talk a little bit about fentanyl and methadone and some considerations for the use of methadone. So with the use of fentanyl and other highly potent synthetic opioids that are currently dominating our unregulated drug supply, individuals have a higher tolerance to opioids due to the potency of fentanyl. And additionally, there's an increased risk for overdose because of the potency and the variable potency of fentanyl, its analogs, and other highly potent synthetic opioids. So just to set a couple examples, the DEA has seized pills with over 500 morphine milligram equivalents, and 42% of the tested pills had over 200 morphine milligram equivalents. So to give you an idea of how potent that is, the lethal dose, or the LD50, is the amount of an ingested substance that kills 50% of a test sample. The LD50 for an opioid naive adult is approximately 250 morphine milligram equivalents. So again, these are high doses of fentanyl that are being found in this example just in counterfeit pills. So additionally, there are many, many other adulterants in the unregulated drug supply, often which have a sedative action to them. So two examples are xylazine and methadomiline. So some considerations, again, when we're thinking about the use of methadone with fentanyl, is that there are challenges with buprenorphine initiation due to the risk of precipitated opioid withdrawal syndrome if only traditional initiation strategies are utilized instead of using innovative low-dose or high-dose initiation strategies. You can avoid any opioid withdrawal syndrome at all if you use low-dose initiation strategies when initiating buprenorphine. So a medication that is not a full agonist, so buprenorphine is a partial agonist, it only partially activates the mu opioid receptors, may have limited effectiveness compared with a full agonist medication like methadone when you're talking about an individual who is using such highly potent synthetic opioids. So providing a blocking dose to treat acute opioid withdrawal syndrome and to address opioid cravings may be more difficult to achieve without the use of methadone. So this is the patient perspective. So this comes from Louise Vincent, who's the executive director of the National Survivors Union, and she is based in North Carolina. And she said this a couple years ago. We have an opportunity to change people's lives, and if we don't get methadone right, we're screwed. I mean, buprenorphine isn't going to do it. The fentanyl is too strong, and people that have been using drugs for long periods of time must have methadone. That's what I hear from other people, what I know from myself. So buprenorphine being pushed is great. I'm glad it's available, but we've got to have methadone. Another thing to keep in mind is even in the carceral setting, we always want to be thinking about when we're treating our patients with substance use disorder is about a shared decision-making model. And what does that mean? It means that patients should be part of their own treatment team, and improving their care by involving them improves their outcomes overall. Patients should be informed fully about risks and benefits of slower versus faster, in this case, methadone titration methods. And patients need to know that they will have opioid withdrawal symptoms for a while, particularly more protracted opioid withdrawal symptoms such as insomnia, before their dose is stabilized. But the goal is for them to not have any withdrawal and not have any opioid cravings. And part of the treatment plan should involve interventions to minimize overdose risk, which we know happens in the carceral setting as well. So again, making sure everyone has access to naloxone, making sure patients are informed, and that there are frequent nursing assessments. The best way to minimize the risk of a lawsuit is to fully inform the patient of all treatment options, help the patient make informed consent decisions, and fully document clinical actions and clinical reasoning. What are some factors that county jails and state prisons should consider for utilization of methadone? So if you have clinicians in your employ that are unfamiliar with the use of methadone, then they should seek support from clinicians with training and expertise in addiction medicine, and specifically in methadone management, before starting patients on treatment. Also, clinicians should be aware of methadone labeling, including instructions for use and warnings. Methadone, unlike buprenorphine, which is a Schedule III medication, methadone is a Schedule II medication and carries requirements for registration, storage, inventory, and records under the Controlled Substances Act. Again, it behooves the correctional facilities to check with state regulators to make sure that there aren't any other state rules that may apply to methadone. So this is just a reminder as to why it's important that the clinicians who are utilizing methadone have expertise in methadone or have access to other clinicians with expertise in methadone. And it's because of the methadone accumulation, particularly early in the treatment with methadone. So methadone accumulates significantly over the first 7 days of its use. And so again, it's important that the individual who is titrating the methadone has some expertise in doing so. Why should my carceral setting have in place to make the hospital clinic approach work? So what are some practical things that we could do to make that process go smoothly? So if your facility is interested in the hospital clinic designation approach to treat people with opioid withdrawal syndrome and or opioid use disorder with methadone, then I recommend the following. Having written policies and procedures that outline which conditions would qualify as a primary condition that would make an individual with opioid use disorder eligible for methadone treatment. Again, we should have SAMHSA guidance forthcoming on that, which will be helpful. You should have protocols and workflows for initiation and adjustment of the methadone dose, a protocol and workflow for communicating with patients' community-based OTPs, if applicable, in your setting, especially during intake at the carceral setting for dose verification and before release, a protocol and workflow for reentry planning for persons initiated onto methadone while incarcerated, So in this example, that individual has no prior relationship with a community-based OTP. So what you want to do in that situation, in which the revised 42 CFR Part 8 rule allows for, is that person can become a patient of the OTP before release. So what the new rules allow for is that that person who's in your setting, who you have initiated on methadone and continue them on methadone throughout their time incarcerated, you can do the admission exam with the OTP via telehealth with a provider from the OTP. So that means that the clinician at the carceral setting can do the physical exam, do all required labs for that OTP admission, then you meet with the OTP clinician. So when that person is getting ready to be released, they're already admitted to the outside OTP, and you can use that DEA 72-hour emergency rule to dispense 3 days worth of methadone to the patient before they leave your setting. So they have no interruption in their methadone access, and they only need to make it to the OTP in the 3 days following their release. You also want to have a relationship with an addiction medicine provider to discuss any challenging cases, a plan to review periodically how well the program is working and how it can be improved, written policies and procedures for DEA regulatory compliance, and a protocol for the procurement, documentation, and safe storage of methadone. So I created a little diagram here for options for medication purchasing in carceral settings. So settings may be doing this differently depending on where they are and depending on whether they're part of a system or whether they're a freestanding county jail, et cetera. So I have the carceral setting in the middle. So that's either a state prison or a county jail. Many of the carceral settings, particularly at the local level, use local retail pharmacies. So that is not an option for methadone procurement. As I mentioned, local retail pharmacies you cannot prescribe methadone for the treatment of opioid use disorder, nor can they dispense methadone for the treatment of opioid use disorder from a retail pharmacy. Many settings use institutional pharmacies. In this situation, they package up your medications for you and then send them to the carceral setting to be dispensed. However, institutional pharmacies are subject to a federal rule in which controlled substances cannot exceed 5% of their dispensing volume. So it's unlikely that you could use your institutional pharmacy to procure methadone. So another option is you can do a direct purchase from a DEA approved wholesaler or distributor. So you can do that. Or an option that I was not aware of until recently is you can utilize MMCAP Infuse, which is a GPO or a government purchasing organization that negotiates the contract prices with the wholesaler or distributor. So you can utilize the pricing through MMCAP Infuse to get the best rates possible for purchase directly of methadone. I'm going to talk about that in another slide. So from the DEA lens, how do you order methadone in a carceral setting? And this was information that I received from the DEA policy section. So a DEA registered hospital clinic is allowed to order Schedule II, so methadone, controlled substance medication, from a DEA registered manufacturer or distributor as they would order any other controlled substance medication. A DEA paper form 222 or CSOS may be used to create the order. I put all the hyperlinks there, and you can find additional information on CSOS at that link. It is possible that the DEA registered manufacturer or distributor that supplies the methadone will want to have a conversation with the DEA registered hospital clinic about the need to order any controlled substance, including methadone. Registrants are required to make a good faith inquiry either with the DEA or the appropriate state controlled substances registration agency to determine if the hospital clinic is registered and allowed to possess the controlled substance. Registrants are also required to design and operate a system to disclose suspicious orders of controlled substances and report those suspicious orders to the DEA. So again, this came from a DEA correspondence. This is a little bit about that 5% rule that I mentioned. So there is a federal regulation that allows a pharmacy whose primary business activity is dispensing to dispense controlled substances. And this is counts retail pharmacies and institutional pharmacies. So the volume of those such distributions cannot exceed 5% of their dispensing volume. So it's designed to provide some flexibility to pharmacies to move stock for ensuring proper filling of medications, but it's also meant to ensure that it limits their ability and they cannot become distributors. So distributors have a different business activity and require separate registration with the DEA. So any carceral setting can order directly from a DEA registered distributor, and that would circumvent the 5% rule of the dispensing pharmacies. And so, as I mentioned, if your carceral setting is only engaged with an institutional pharmacy, those are dispensing pharmacies and have to abide by the rule. So a little bit more, this is a very wordy slide, but I wanted you to have the information written here. And I also included the website at the bottom, but I worked for government for 3.5 years and had never heard of MMCAP Infuse. So as I mentioned, this is a group purchasing organization for government, and it is operated out of the state of Minnesota Office of State Procurement, so an actual state office. And it has contracts with all 50 states. And what it does is it negotiates on behalf of the states with the distributors to get the best possible rates for purchasing of pharmaceuticals and other healthcare products, such as healthcare devices. So there is no cost to participate in with MMCAP Infuse for members. And so there are many healthcare facilities, and these all have to be government entities. So at the county level, at the state level, or at the more local level. And public health facilities comprise half of their membership, followed by educational institutions, correctional facilities, and public safety. They also employ 6 regional senior healthcare consultants. So there is a senior healthcare consultant assigned to each region of the country and covers all 50 states as well as the US territories. So this is a great option for carceral settings, and it might be able to circumvent higher prices that you might have if you negotiate with distributors yourselves. So I wanted to share Washington State Department of Corrections uses the hospital clinic designation for all of its state prisons. And so I wanted to just give an example of how they order medications in their system. So they have a central pharmacy that functions like a pharmacy in a hospital. They order their orders in their EMR, and they are considered orders, not prescriptions. They're filled by their own central pharmacy. Their controlled substance supply is ordered and stocked at the facility level, and then it gets shipped from facility stock that is kept on hand. So methadone is ordered from distributors like any other medication stocked in their facility. And then when an order is placed, it is filled from stock that they carry on hand, just like in a hospital. So essentially, their DOC system functions within their own central pharmacy system. She acknowledges, the addiction medicine medical director who I spoke with, that this may be different from other jail or prison systems, which may not have their own central pharmacy system, but may be using, for example, a retail pharmacy or an institutional pharmacy. They're still trying how to figure out how to do the 72-hour supply at release. So they're actually talking to other systems, including hospital systems, to find out how they're documenting that, and then they're going to mirror that in their own facilities. Because you all may be new to doing the hospital clinic designation, it does make you potentially subject to a DEA audit. So I thought I am not well versed on DEA audits, but I wanted to include some information for you to go to what carceral settings should know about a DEA audit. So I included a lot of helpful links here to make you more informed if you do choose to use this route. So I recognize that there are lots of complexities about relationships in the carceral setting. So here is just my version of what some of those complexities can look like, with the carceral setting being in the middle. with health vendors and medication distributors on the right-hand side. Above the carceral setting, the federal regulators. To the left of the carceral settings, you have national associations, county regulators, post-release services. Down at the bottom, state regulators. So I recognize it is a very, very complex system to navigate, but hopefully I've given you some clear information that will allow you to consider pursuing this option. So just a little bit about medication distributors in the United States. About 92% of prescription medicines in the United States are distributed through wholesalers. So the biggest three are AmerisourceBergen, Cardinal Health, and McKesson Corporation. They account for more than 90% of wholesale medication distribution in the US. Carceral settings using the hospital clinic designation, as I mentioned, do need to get methadone from a DEA registered distributor. Unfortunately, there is no public listing of DEA registered distributors, but I'm pretty sure that all the big ones are DEA registered distributors. Just a word about healthcare vendors in US carceral settings. By 2010, about 50% of US jails surveyed by Reuters had turned to privatized medical care, and by 2018, 62% utilized privatized services. There are a handful of companies that dominate the jail healthcare business. I've listed them there. So again, important that this is a conversation between the carceral setting, if they have outsourced medical services, with your healthcare vendor, as well as whoever is providing medications to your setting. Another option, people are probably concerned about cost, though methadone is very, very inexpensive as a generic medication. So a possible solution is Medicaid pre-release 1115 waiver. So that may be a solution at least 90 days before discharge regarding cost. I put up a map that was current as of April 2024 of the states that have it approved and those that have it pending. Just a reminder that there is a lot of stigma towards people who use substances and towards effective treatments for opioid use disorder. So a couple of quotes here from Nora Volkow, who is the director of NIDA. While attitudes around drug use, particularly use of substances like cannabis, have significantly changed in recent decades, the use and possession of most drugs continue to be penalized. Punitive policies around drugs mark people who use them as criminals and so contribute to the overwhelming stigma against people contending with an often debilitating and sometimes fatal disorder, and even against the medical treatments that can effectively treat it. And from the National Academies for Science, Engineering, and Medicine document called Medications for Opioid Use Disorders Save Lives that was published in 2019, buprenorphine, methadone, and naltrexone save lives and are effective in reducing illicit opioid use, reducing relapse or return to use, protecting from overdoses, promoting treatment engagement, reducing criminal involvement, and improving functioning. Moreover, these effects are evident in every subpopulation with opioid use disorder. Thus, we must recommit to addressing the barriers to treatment, including stigma and the shortage of clinicians capable of providing medications for opioid use disorder. So in conclusion, methadone is a life-saving medication for individuals with opioid use disorder. Carceral settings should be providing the community standard of care for the treatment of acute opioid withdrawal syndrome and opioid use disorder, including the use of methadone. The updated 42 CFR Part 8 rules clearly allow carceral settings to utilize the hospital clinic designation to provide patients with methadone for the treatment of acute opioid withdrawal syndrome and/or ongoing treatment of opioid use disorder without becoming an OTP or having a relationship with a community-based OTP. The patient must have another diagnosis besides opioid withdrawal syndrome or opioid use disorder. And as I mentioned several times, there should be SAMHSA guidance that is forthcoming. Carceral settings who use the hospital clinic designation should have policies and procedures, protocols, and workflows in place detailing how the specific federal, state as applicable, and county as applicable regulations regarding methadone in carceral settings will be addressed. I have included a lot of resources in the slide set. So these are clinical resources on treating opioid use disorder with methadone. I have two slides with resources there. And then all my references are listed both on the slide and at the end of the slide set. Included my email here in case anybody has any questions. And I'm happy to take the rest of the time for any questions, and any questions we don't get to, we will address at a later date. Thank you.